We're joined today by Dr. Robert Ross, who is the president and the CEO of the California Endowment. And, as folks know, he is the president and CEO, but he has provided leadership for decades in serving underserved communities and grassroots efforts for a healthier California, of course, but also a healthier America. He has an incredible background as a public health administrator. He served as the commissioner for the Philadelphia Department of Public Health. And among his many board positions, he served as the founding board member for Covered California, which is amazing. He also will be a Stanford University Distinguished Visiting Professor for the 2023 academic calendar. So, Dr. Ross, would love to turn over the virtual stage to you.
Thank you, Shruti. I hope all can hear me well. Good afternoon, everyone, and welcome to this amazing gathering around the matter of the social determinants and the social drivers of health. I want to thank our partners at California Blue Shield for being co-hosts and co-drivers on this conversation. Really critically important for us institutionally at the California Endowment, for the social drivers of health and health justice and health equity really constitute the cornerstone of our work at the California Endowment. But for me personally, and I'm going to actually frame the panel discussion, Shruti, to get a little bit personal about this. Because social justice is a personal endeavor. It has to strike you as something that is morally compelling and morally persuasive and critical, and I believe this issue is. But I was introduced to the social determinants and the social drivers of health as a young pediatrician serving on the East Coast in Camden, New Jersey, and in North Philadelphia, where I served at community health centers there. And it was in the late 80s and early 90s when crack cocaine was visited upon the United States. And for those of you not old enough to remember those days, before the 1980s, poor people couldn't buy cocaine because it was too expensive. And only the wealthy and the rich could buy it in the powdered form, which was very expensive. But some evil genius invented crack cocaine, and all of a sudden you could buy cocaine in powdered $5 and $10 doses, and it became not only accessible to the poor and low-income communities, it became the rage for inner cities and urban America just across the entire nation. And I watched as crack cocaine was introduced into the communities I was serving in Camden and in North Philadelphia, and it wreaked incredible health havoc on that community. We saw increases in infant mortality and domestic violence and child abuse and neglect, increases in drug overdoses, increases in sexually transmitted diseases because women, young women who were addicted to crack cocaine were selling themselves for the drug, and it was an eye-opening and sobering experience for me as a pediatrician who was dedicating his life to becoming a healer in the community. And it was my rude introduction to the social drivers of health and the social determinants of health. And we also saw Black people and brown people criminalized. Instead of a massive increase in mental health and substance abuse treatment services across the nation, those who were selling crack or using crack were criminalized and sent to jail. And we saw a massive increase in the criminal justice population and the incarceration of the 400% increase in incarceration across the country as a result. And so I became both intrigued and bitter as a pediatrician, as an African-American pediatrician, watching what was happening, not only in the community I served, but across the nation. And that's what turned me on to becoming intrigued and smitten with the thoughts of dedicating my career to the social determinants and the social drivers of health. And the next 20 years, as I found my way into that work, joining public health departments and ultimately getting into philanthropy, it was a frustrating time. It was frustrating to see year after year the health system refusing to acknowledge the social determinants, the social drivers of health, dismissing it as not part of our business. We deal with healthcare inside the four walls of the health system, and what happens in communities is really not our charge and not our business. And in the last decade or so, that's begun to change, thankfully, in meaningful ways. And we see the health system beginning to acknowledge the social drivers of health. And not only beginning to acknowledge it, but as this conference is demonstrating, beginning to center the social drivers and social determinants of health as core to wellness and healthcare in the nation. And furthermore, acknowledging the role that race and place play in the social determinants of health. We know that we can no longer tolerate living in a nation where one zip code is determining one's health destiny, and we would include race in that as well. The good news is that there's great progress beginning to unfold. You'll be inspired by the panelists that will follow my opening remarks. It's just really fabulous and incredible to see. But we are now on the verge of turning the social determinants of health into an intriguing and impossible journey and task to take up, into an approach that is accessible, is doable, both pragmatically and through inspirational innovation and partnership and collaboration. We're beginning to make progress on the social drivers, and I'm just thrilled to see the health system generally, and our colleagues and partners at Blue Shield in particular, taking up this issue and centering it for all of us. So welcome to each and every one of you. Enjoy the panel and you'll be inspired.
Thank you so much, Dr. Ross. Really appreciate you taking the time to be here with us today and partnering on this three-part webinar series. As I mentioned, if you missed earlier, for folks just joining, this is a part of a three-part webinar series where we are focused on innovative collaboration to really support the social drivers of health. And with that, I would love to welcome the panelists up on the virtual stage. Hey there, Kitty, Dee Dee, Andre, so amazing to see you. And as Dr. Ross, what you guys don't know, in the green room backstage, Dr. Ross pointed out he and Dee Dee are very twins-like today, which is awesome. If there's anybody that you'd want to be a twins with, it'd be Dr. Ross for sure. But would love to kick off this panel. All three of you are so accomplished and do such critical, amazing work in this space. So I didn't want to say it for you, and I wanted you to be able to introduce yourselves and talk a little bit more about your work in this field. So why don't we go ahead and start with some introductions, and if you can tell us how you are supporting social drivers, that would be wonderful. Dee, why don't we start with you?
All right, thank you. I am Dee Dee Johnese. I am the Vice President of the Health Transformation Lab at Blue Shield. I lead a multidisciplinary team that focuses on solving some of the most challenging and persistent problems in the healthcare system, which makes for very fun Tuesdays. And inside my team, though, inside of my lab, there are 6 teams focused on various aspects of the healthcare system, including community health and population health equity. So every day we get up and try to figure out how we make the way we deliver healthcare through and how we partner with our healthcare provider partners to deliver healthcare more equitable, how we improve the health of whole populations, but also we get to learn every day, honestly, all the ways that we fail to do it. So I've been doing this kind of work now for about a decade, in and out of healthcare. And it doesn't get easier, but every day and every tiny win is very rewarding. So I'm happy to be here.
Love that, Dee Dee. Kitty, what about you next?
Hi, everyone. Kitty Bailey. I am the CEO of the San Diego Wellness Collaborative, which is a nonprofit organization here in San Diego County focused on improving health equity at a population health level through our cross-sector collaborative initiatives. So I'm very privileged to get to work with so many wonderful partners in San Diego County. We have 3 initiatives that you can learn more about. One is Be There San Diego, focused on building community clinical linkages to prevent heart attacks and strokes. We also house the Accountable Community for Health, which I'll talk about in a minute, but that's focused on addressing the root causes of health inequities. And finally, we have Neighborhood Networks, which is an innovative social services IPA model, where we're bridging the gaps between MCOs, managed care organizations, and community-based organizations who have those boots on the ground community-based workforces. So very happy to be here today.
Thank you, Kitty. And Andre.
Hey everyone, Andre Ostrovsky here. I'm the managing partner at Social Innovation Ventures. I invest in diverse founders that are trying to tackle challenges serving Medicaid and those populations. I've had a couple of operating roles in the past, and I've had a couple of government roles as well, most recently as the Chief Medical Officer of the Center for Medicaid and CHIP Services. And I'm excited to chat with you all and share some late-breaking research. Thanks.
Thank you all for being here. Truly, your expertise spans across kind of the ecosystem when we are considering this. So my first question really is around how can healthcare, and I say healthcare, community organizations and technology innovators work together to address not just individual social needs, but also social drivers of health to build healthy, resilient communities? And maybe, Kitty, we can start with you.
Sure. I really appreciate this question. I think the spirit of the question is such a great place to start, because really understanding that the social drivers of health and individual health-related social needs are so interrelated, and yet they deserve 2 separate conversations and to be considered distinctly. So we know that the definition for the social drivers of health are the broader conditions that affect folks' ability to grow, thrive, live healthy lives in the community context, and the economic policies and systems, social norms, and the political system. So those are these broad drivers of health that then create or contribute towards individual health-related social needs, which so many of us on this call are working with day in and day out in terms of helping folks address those individual social needs, which are really health-harming conditions such as food insecurity, housing insecurity, lack of transportation, which is where we really are engaging, I think, that community-based workforce today. So first, I appreciated the opportunity to call out the differences, and then the need to really look at both levels of that work. And so with this question, I think I'll just dive in a little bit on how we in San Diego are addressing those broader community contexts that we would call the social determinants of health. We really do that work. I'm very lucky that I have the 3 initiatives I described, because we get to work on both levels of the social determinants of health and individual social needs. So when we're thinking about the social determinants of health, we're really deploying our version of the California Accountable Community for Health, which is a part of a funded initiative called the California Accountable Community for Health Initiative. People can check out that website. I'm sure they'll put a link in the chat, catchy.org. And it's an exciting initiative because it's really about transforming the healthcare system into a system for wellness and community health by bringing siloed partners together to a table. We know that health cannot be created just inside the 4 clinic walls. So our work as the ACH here in San Diego is to bring all the partners together and have them create the context of doing business together in new ways, building new kinds of relationships, and creating change. So as I was reflecting on this call today with you all, I thought about what's an example of a way we've done this in San Diego that can really highlight the power of bringing the partners together. I'm sure everybody in the call is aware San Diego is a big county. And so when we think about doing this work, we come in and we hone in. And so we created a project focused on nutritious food access in the North Inland region of San Diego County. And we brought together healthcare systems, federally qualified health centers, community-based organizations, the schools, the Head Start programs. And together we really dove in to addressing the problem across the spectrum of domains, from social determinants of health to health-related social needs. So how are we accessing food? How are vulnerable communities accessing food? But how are we ensuring that we're screening for food access, that we're making more food available, that we're ensuring nutritious food is available, accessible, and usable by our populations of focus, and of course, inviting public health department to the table to share all their wonderful population health data that they have access to, so we can track ongoing whether or not we're having an impact. All these great partners came together, they created a robust agenda around this, and we now are tracking this in a way that had never happened before and creating synergies that had never happened before. So that to me is an idea of how you bring this to life in a community.
It's amazing. And Andre, would love to also hear your, given the lens of you being an administrator and now you're on the investment side, what are your thoughts on this?
It's pretty complex. I think it's important to align social services with payment. I think that's where there's a pretty big gap in making sure that social risk factors are adequately remedied and remedied at sufficient scale. There's research that I've been doing with colleagues from the American Board of Family Medicine Foundation, whereby we convened 2 different workshops in earlier part of this year. Each workshop had about 20 participants, and the participants span government, insurance carriers, providers, consumers. And we looked at how might we design a future state whereby risk-adjusted payments take into account not only medical complexity, which is the current state of affairs, but also to incorporate social risk factors into risk-adjusted payments. And there are some really interesting findings, which I'll share in the chat, a full synthesis of those findings. But some of the highlights include things like a really significant disconnect in trust between consumers and the healthcare system, including insurers, including federal government, state government. There was some trust with primary care providers, and there was a lot more, really the most trust was with community-based organizations. It's those folks that are on the ground, living alongside of where the consumers and beneficiaries are. There's also another interesting finding that when looking at social risk factor, risk adjustment, there was a willingness even among insurance carriers to incorporate not just individual variables like a SDOH survey that's administered one patient at a time, and while it can be helpful in targeting, is also very gameable by the insurance carrier, but also incorporating community variables like census tract level data, which no carrier or provider can gain. And there's some really interesting implications there that for those folks that are listening and are familiar with the ACO REACH model out of CMMI, that was one of the first attempts to risk adjust using community variable like the area deprivation index. And so a lot more juicy and deeply wonky insights in the document, which I'll just share here in the chat. And I'm quite excited to see the progression both at the federal and the state level to see alignment between payment and addressing social risk factors.
Yeah, these are just some really great points. Make sure to check out the chat with what Andre is going to drop in there in just a second. A follow-up sort of to that question is, how can we break down barriers and build coordination between healthcare and community-based organizations? You know, what does successful coordination actually look like to address social drivers? And, you know, what are particularly promising and innovative approaches? So maybe Dee, we can start with you for this one.
Yeah, I feel like I'm trying to think of like something else to say except what Kitty said. No, Because I mean, there's so many things, right? I mean, I think we do well at this point. The fact that we have established great relationships, and I'm going to talk about some of the relationships where we've been really successful in working with community-based organizations. But I think if I had to top line it and think of some of the things that, you know, either we're starting to do or the things, honestly, I wish we were doing to break down some of those barriers and build coordination. I think one of those things would be to sort of to volunteer more and cross-pollinate with with community-based organizations more, and sort of not when I have a campaign or a pilot going, but so that I can get deeply into the bowels of what's happening and really understand it. And then also get inspired by it, right? And understand how we could help scale it. And so I think that that's probably the you know, the big thing that I think we can do as big workforces at healthcare organizations: get in there, volunteer, and then also volunteer to provide our expertise to those organizations. I think a second thing that we can do is really, we talked about social drivers of health versus just addressing social needs. In terms of social drivers of health, I think employing our anchor strategies and going in there and renting space, co-locating if we can, putting in those community centers. And I know we've done some of that as well. I'd love to do more. I think co-locating in the community, even in the same building, gives us an opportunity at organic collaboration, and we get to see the insides of each other's organizations. I think the other, though, is we talked about getting ahead with social drivers. I think we have to do things like make sure that we have providers, right? Because I mean, we're a health plan, making sure we have providers in communities. And I think that piece is really, really key, because if we start to put our own, make sure we have providers there so people don't always have to go to the ED or things like that, or making sure that we are attracting investment by being there, right? We can attract others to put amenities in communities and thereby address those non-clinical factors that determine people's health outcomes more than the clinical ones do. And then finally, I would say, and it's like tiny compared to all the other ones, I think we need to share more about what we need in terms of being able to document success, right? We're all about doing the work, us and the community-based organizations, but I think where we don't always intersect is in how we document what is done, how we document success and report out to the organizations that can then ensure that everybody's needs are met. Community-based organizations get more dollars and other resources to grow their capacity and sustain it, and the healthcare organizations get the data and documentation that they need. I mentioned I think we've done well at this in a couple of places for sure. Recently, starting last year, we partnered with community-based organization like Her Health Foundation and the Diversity Uplifts and the Black Wellness and Prosperity Center. And we also partner with a mission-based for-profit in Maumee to help Black mothers and Black birthing people deliver healthy babies, right? Something near and dear to my heart. In that work, what we did was provide not only for the individual social needs of the mothers and Black birthing people, but we also provided healthcare from providers who were people of color, a platform through which they could access those services and supports. We also provided listening circles and doula support at every step before, during, and after delivery. And the outcomes have been amazing so far, right? We've had 99% say, I'd loved it, I'd recommend it. But more important than that, we've seen lower rates of self-reported depression, right? We've seen 47% deliver full-term babies, and we've seen a lower than the national and California average, heck, lower than our own average delivery of C-section births. And that's been amazing. And that's because of the collaboration. We weren't able to reach out directly to Black mothers and birthing people, but we went in and we talked to organizations who were already doing it, and we were able, through them, to deliver this care and service and support and get these amazing outcomes in partnership with them. And I'd say second place where we saw some amazing collaboration and something scalable, reusable that we can each keep going back to was during the COVID work last year, we worked with a bunch of community-based organizations focused on, Asian Pacific Islander communities, Latinx communities, Black communities who were hit hard by COVID, had a huge vax gap with other communities. We were able to go in to together to use a platform for patient and community engagement, syndicate information between us, optimize our information, use data to target the communities and zip codes who needed our help the most, and get 65,000 Californians vaccinated, right? Love that. I think there's a lot of power in these kinds of collaborations. So I could go on, but please make me stop.
So Shruti, could I ask Didi a quick question? I follow
Yeah.
what you just mentioned. Didi, you mentioned housing. One thing from the research findings that I put into the chat was a really interesting delineation of where health insurers should play a role in addressing social risks and remedying the gaps. And you mentioned things like doula services and navigation services, and there was general consensus that that's a great role for an insurance carrier, both on Medicare Advantage and the Medicaid side, to get involved. But when it came to things like housing, there is a hesitation by some folks across the full stack of participants, consumers included, where they said, you know what, is the healthcare system and insurers really the most efficient use of dollars for housing, for example? And there was kind of a pushback to say, well, actually, maybe things like HUD and HUD's programming and the existing piping, that is actually a already well circumscribed mechanism for administering like a housing benefit or housing related services, and similar things like the SNAP benefit for food, as opposed to going through an insurance company where there's, MLR, administrative spend inefficiencies. So I don't know if you have experience there, but it'd be pretty cool to get your perspective.
I do have experience there in another life with another payer where we did do this work. And I will say that we heard a lot of that, right? The pushback about, heck, forgive people's, medical bills, especially if they can't afford them. That might be a better use of health plan funds. And I won't weigh in on whether or not I think that's, true or not. What I will say, though, is that I think the idea of using an anchor strategy to approach all of the social drivers, I think you have to do it, right? I think minimally health plans had to try it. I think maximally they need to figure out a more scalable way to do it, because at this point it still ties the dollars back up with the same old investors and the same old development companies and the same old assisted living organizations, and I think becomes a little bit of a stopper from getting the information to people. Getting the dollars to people. So I guess I did give you a little bit of my opinion there, but I do think I don't want to stop the idea that that healthcare organizations lean out for the drivers, but I hear your point, and I hear the people's point, right? Like, maybe stay in your lanes a bit, don't muck it up, energize or support the work of organizations like public organizations that do this work better than us, and that makes sense to me from an efficiency standpoint for sure.
And Kitty, I'm curious, your perspective, the community perspective on the coordination and anything else that was sort of mentioned.
Well, I think we're at such an interesting inflection point here in California with CalAIM, where Department of Healthcare Services actually decided to start creating benefits that are for the social needs, like housing, for example, like food and meals. And so we could debate the merits of that as a policy decision, but at the same time, we're actually in the midst of trying to roll it out, currently utilizing the community-based workforces who do have the trust of the community. So I think this is where I'm currently spending a lot of my time, is with our neighborhood network social IPA model, where we're really trying to connect those trusted grassroots organizations who have the trust of the community, have the relationships, deeply understand their communities, with the managed care organizations who now have responsibility for things that they've never had responsibility for before, and maybe recognize, as Didi was just saying, that there's other experts who they should be working with on these things. And so we created an intermediary model, and this is very replicable. So I want everybody on the call to feel inspired by this and not feel like, well, that could only work in San Diego. No, I mean, this is a model that we're used to working with in healthcare. It's just like an IPA, but for a basis of community-based organizations who can deploy community health workers or housing navigators, or what we're calling lead case managers under the new enhanced care management program. These are all kinds of new workforces who are now eligible to receive reimbursements, and they're out in the community doing good work. We are struggling with this as a moment of opportunity because there is so much work to be done to make this work well and not just end up creating chaos and confusion with the Medi-Cal membership, with the communities themselves, with community-based organizations. And so I'm spending a lot of time these days figuring out, how do you create these linkages between the CBOs with the boots on the ground and the managed care organizations who are trying to be very responsive to the new set of responsibilities been placed on them by Department of Healthcare Services, and creating a lot of learning, a lot of trainings, a lot of data integration. And yes, I see the question in the chat popping up. We are working with community health workers specifically. I know we're using that broad term, community-based workforces, but we are specifically using community health workers to do this. But there's so much to be learned. And there is a tremendous amount of resources coming out and available through the CalAIM grants. I'm sure many on the call are aware of those. So the Children and Youth Behavioral Health Initiative, through the new Office of Equity, through the ACEs Aware grants. And so what we're doing in San Diego is we're taking a holistic point of view and seeing these not as siloed efforts of new kinds of funds with new interesting requirements, but how do we look at that holistically? How do we take that big picture point of view and integrate ACEs Aware with CalAIM, with the Children and Youth Behavioral Health Initiative, with the Office of Equity work, with the California Reparations Task Force work that's happening? Because by combining all of those and looking at them as a whole with all of our partners here in San Diego, we believe we can create a really powerful new way of doing business in San Diego. And this is something that every community around California could be doing the same sort of work. And we're very excited. I'm happy to share our neighborhood network social IPA model with other communities that might be interested in doing something similar. I'll just pause there because I think that's probably a lot.
Yes, it's amazing. It's, I hear this theme, each of you has brought it up, of mutually beneficial relationships and also having the necessary resources really when considering coordination, any of these things. And so as we look at, the number of health plan partnerships with CBOs, like that is continuing to rise. But we look at, how do we make these mutually beneficial relationships? What can we do to support CBOs that may not typically have the relationships with plans and providers? And specifically, how can we build the capacity or help support building of the capacity, I should say, for community-based workforce to ensure they have the necessary resources? Maybe Andre, we'll start with you on that one.
I'm sorry, Shruti, could you just repeat that question one more time? I had a connectivity issue.
Oh yeah, sure. I was just saying, we've been talking about mutually beneficial relationships. So when we consider kind of how health plan partnerships with CBOs are continuing to grow and how we can be good partners, how can we support CBOs in this
Gotcha.
work that may not have to be
Yeah, I think there's two perspectives that I'd share that, again, it comes back to findings from the workshops I'm referencing. One is that there is an infrastructure need amongst CBOs, in particular, community-based organizations often are not nearly as well prepared as clinical practices to do quality measurement or quality reporting. They're not as well prepared to receive, administer, and then report on use of funds. In most cases, they are very ill-equipped to take on financial risk. And so even most practices, frankly, are not really well equipped to do that in the clinical setting. But when we're talking about non-clinical provision of services, there's a real deficit, a real challenge there. There's also constraints around IT infrastructure, as well as change management capabilities. A lot of these community-based organizations, their value and their core competence is in building the empathy and providing the direct services to consumers. They haven't traditionally invested in having a chief quality officer, for example. And so I think building and investing in that infrastructure is really important. There's precedent in doing that at the both community-based organization level, especially with home and community-based services across the country and in certain states, including California. Massachusetts is another one with pretty good infrastructure building efforts. But there's also like the TCPI program that was sunset out of CMS, where there was practice transformation dollars to primary care practices. And quality improvement organizations as well have a certain track record of building those types of that type of infrastructure. So that's one aspect of that's really important to proactively take care of, and building the relationships and partnerships between CBOs and payers. And then there's the dollar flows. The dollar flows have to be aligned. They should. One thing that's happened in the past that I think should be avoided, not necessarily in California, but definitely in other states, is community-based organizations' dollars tend to be tied up with providers, clinical providers, especially health systems, hospitals, and that reinforces the medical model of care, and that's not necessarily very whole person or person-centric. And making sure that community-based organizations are essentially on level footing with health systems in buying for the dollars, especially when they don't necessarily have those grant writers like the health systems often do, or the infrastructure that I previously alluded to. So dollar flows need to acknowledge the lack of infrastructure, building infrastructure, and then ultimately rewarding community-based organizations for the value that they produce. And as with everything, it all should be evaluated and measured. And that's where health services researchers should get involved. And that shouldn't be a burden on the CBOs, right? That should be an external entity offering that support of evaluation, so that ultimately we can see both the clinical impact, the social impact, and then we all care about cost and value. We also should maybe prepare mentally and set expectations that these aren't going to be cost saving partnerships, or at least not in the near term. In the long term, very much high pretest probability that they will be net cost savings, but for quarter to quarter reporting purposes, that'll be tough. And that's a mind shift that probably needs to happen to make these partnerships successful.
Yeah, Didi, I'm curious, health plan perspective.
Well, I was smiling because I'm like, did he say don't focus on cost savings? I don't know. Sorry, when I was thinking about this one, I think, again, this is one of those, my goodness, like where to start. But I think one of the good things that's happening right now, and Kitty brought it up, was that we have market demand and at least a very good start on aligning payments and the funding flow, right, by virtue of now having a lot of the social needs pieces, not a lot, not all of what I'd want to see, but a lot of what we would need to provide services to meet social needs are now going to become benefits, right? There is now this reimbursement piece, which I think goes a long way toward what Andre was talking about, which is making it so that they can have level footing, because before we were trying to tuck it into payment models that go to providers. And I think now, if there is a reimbursement and there is an opportunity to contract directly in order to get this done, I think it's a big opportunity, right? And I think people should see it as this massive shift in the paradigm. I think the other thing that we can look to is, I think there's another big opportunity here, which is that at a time when healthcare organizations should be like able to target and meet individual social needs, we're still way up here trying to get folks to trust us. All right. And still trying to do what Andre was talking about, which is find the place we should properly lean in, right? In some cases where community-based organizations have already they're over the trust barrier. They're delivering the services, maybe not at the scale and maybe not with the resources that they need, but they're doing it. And I apologize for the noise because I have construction going on, but let's call it a building metaphor. So about building and sustaining capacity for community-based organizations. And when I think about that opportunity and the fact that, you're already doing something that we need, I think this is a great opportunity to take that leverage you have right now as community-based organizations who've already got the trust to come in and try to change the relationship you have with us, right? Somebody mentioned grant-based relationships. I know it's blasphemous, but I'm all about let's talk about having contract-based, right? Contract-based partnerships. I mean, nonprofits are nonprofit, not non-revenue, right? Revenue is key to sustainability. It's key to paying your teams. It's key to paying for that technology investment and maintaining it, right? You need that. The other piece that I think that we can do as health plans, since we know now we need you more than ever, is we can incentivize you to close the gap. I saw people writing about closing the loop, right? And we've been looking for, it's like the holy grail in this work right now, because it's hard, right? We have this uneven balance of resources in order to be able to do this. And we're so far ahead on technology, which is funny if you're in financial services listening to healthcare saying they're far ahead in technology. But since there is this imbalance in the resources, I think that we can do more. We can incentivize in the ways that we've incentivized healthcare providers to change the ways that they focus on social needs of their patients. We can start to think about how do we incentivize community-based organizations to close the loop, and thereby, in addition to paying for the services that are being delivered, now we're paying for, through the incentive, the additional administrative lift, the additional technology maintenance lift that it takes to be able to give us the reporting that we need in order to get that reimbursement and then share any upside or savings with you, right? And so I think that piece I love. And then last piece I'll say on this is that we've been investing, Blue Shield and, partners, competitors, we've been investing in platforms to try and make it easier for community-based organizations who choose to join sort of centralized platforms, referral networks that are not built for any particular plan, but for all of the plans to leverage the community-based organizations at scale. I think use those if you are inclined to. And then the entrepreneur in me says, but by all means, and for the love of all that is good, go and make your own, right? Place-based, community-based organizations, getting together and creating your own network. Don't try to build these massively robust platforms, because I gotta be honest, I'm like, if the healthcare system has limped by on faxes from providers, I am not suggesting people fax us things. However, there has to be a digital equivalent, a feed, an open source API, something that will allow for the community-based organizations to keep driving their own destinies and not necessarily have to, if they don't want to, join a platform, but be able to do this work and get compensated at the level that they need to in order to keep reinvesting in their organizations and the communities. So those are my few bits.
That was beautifully said. And it was as if I paid you to set up the next question. This is the last question before we turn to audience Q&A. But throughout the discussion, and Dee Dee just mentioned it as well, we've mentioned data and funding, and they've come up as critical components. We're actually, the two remaining sessions in this 3-part series are focused, the next one is focused on data, and the one after is on funding. So again, make sure you're registered for this so you can get notifications for those two. But in thinking about that and discussing for our panelists here day. These three components, when we think about how they fit together as the essential building blocks for achieving our broader goals for addressing social needs and social drivers, can you talk just a little bit more about that and thread the needle for all three? And let's start with community this time with Kitty.
Well, just broadly, I would say we should challenge some of our assumptions that we're going into these conversations with, which is that not all CBOs think this is a great business deal for them. And there's really got to be an ROI for the CBO. A lot of these are big organizations taking huge social services or food contracts or housing contracts. I'm having a tough time creating their ROI on their end to show them why they should take the CalAIM contracts of ECM, CS, or CHW contracts. The rates are not great. So I just hit funding. I didn't hit data yet. I would say the other thing to think about, what are the unintended consequences of what we are doing? We are making huge shifts in giant budgets in this state, and there are going to be unintended consequences if we don't think seriously about the disruption this creates at the community level. So some things to be thinking about for your next two sessions. I look forward to being a participant in those.
What about you next, Andre?
I think the angle I would take on this is what is the role that technology can play in weaving all these threads together. And even though the primary way I spend my time and most of my money is investing in technology companies, I think it's important to reiterate that it's not technology that's going to solve most of our problems. It's trust. And if there's trust between the care team, however we define it, and more importantly, however the person defines it, that's how we get compliance. That's how we get engagement. That's how we get appropriate services navigated and actually provided. Technology can streamline that, and I think that there's a lot of promise there. And so I think it's always important to look at some of these issues and any problem, frankly, in the healthcare space and think, where are there inefficiencies that technology can help eliminate? And how can we ensure that technology is freeing up more time for trust building? Not how do we replace the trust with technology? And I know it's somewhat of a generalist view, but that's been my investment thesis so far. It's panned out to date. I used to be an investor in City Block, for example. I got out not because I don't trust the model, it's just that from a financial threshold perspective, it made sense. But that's an example where you have the technology-enabled primary care. Still primary care, still using CHWs. There's just the efficiencies created. And there's some investments more recent that I'm still actively involved in, where Inquisit Hub, for example, is a virtual network of CHWs. And it's folks with chronic conditions that are well controlled, that are communicating with people from their community, similar language and cultural context. And technology just helps ensure that there's quality assurance in place for consistent care pathways and good virtual experience. But the human component is still key. So I think that's a key takeaway here.
Am I getting in on that goodness, Shruti?
Yes, you are. Yes.
Okay. So I agree with Andre on the technology, right? It's a means to an end, and I'm going to bring back I think the means to bringing forward community-based organizations as equals in the how do we make communities and people healthier, right? Health plans, healthcare providers, others, plus CBOs. I think being the entrepreneurs that many of them are already, but bringing forward the platform as a way to get scale and also as a way to make sense of the math, right? If I have to deploy a whole human and the whole human needs to stay with you for 9 months or 12 months, right? It does need to be a sustainable sustainable, like living wage better than, right? Something where I can, save and reinvest and have a great life, thrive, not just survive. So I think technology goes a long way toward that. But I think another interesting piece here that sort of strikes me in terms of the data funding relationship between community-based workforce too, we have a big data gap too, right? We talk a lot about data like we have it all, and it's just a matter of how we efficiently and effectively share it. But actually, we have a massive data gap, especially when it comes to people of color, communities of color, especially when it comes to people who don't speak English, right? The predominant language that a lot of these sites and apps are in. We're missing the data, and it doesn't mean that the people don't need the care and services. It just means they're not participating in the predominant platforms or the ways that we've decided to make it available, right? And so I think the community-based workforce is really critical to actually helping us fill the data gap so that we are deploying toward the right things. If the people don't think it's housing, then, let's understand the people better. And so I think that community-based workforce is a way for us to do that. And I think the way that we can help, and I'd mentioned this a little bit earlier too, is about sharing the how, right? Because I honestly don't think, like for me, I take a janky old feed where you just sent me all the required information, but I had to unscramble it like, Soul Train while other people danced in the back. Like I'd be into that. And I think most health plans would take that over no data at all, right? And so I think it might just be that simple in the beginning, a sharing, a liquid sharing of information that is direct between the CBOs and the healthcare organizations versus through middlemen and other organizations. And I think we can do that. So, and then, I said that last piece, funding. Everybody get funding, everybody get into revenue driving relationships. Because the grant thing, I love it, has its place, but it's hard to make sustainable and multi-year. Those are my bits.
Yeah. I love ending the panel bit with talking about Soul Train and janky feeds, by the way. That was amazing. I think we have time for one question, but if you did submit a question, don't worry. Like I mentioned, we're still going to answer all your questions. It's just going to be in the post-event follow-up where you'll get the recording of this session, plus the answers from all the Q&A. But our first and only, I think, audience question, you guys are just too good. There was too much to discuss, is reading off my phone, not texting, I promise. Are there best practices out there where aligned purchasers and payers effectively incentivize more meaningful partnerships between counties, CBOs, and health delivery systems to improve access to equitable social, behavioral, medical services? Kitty, let's start with you, and any best practices you may also be able to share from Be There San Diego.
Well, I think we're at the precipice of trying to come up with some really innovative solutions on how to create alignment between these disparate funding streams, so that we have exactly what that question is implying, where instead of having these very separate funding streams coming in and funding lots of different activities that end up being uncoordinated, that we as a ecosystem, whether or not that's a regional healthcare marketplace or the state or some other kind of networked group, we come together and we figure this out. I think we're striving for that, and we're aspirationally trying to work towards that. I mean, I think creating neighborhood networks as a social services IPA was a way to like fill a hole because we don't have that more comprehensive approach. It's sort of a hack within the current system versus the idea of really redesigning the system to make more sense. So that's my best thought at this point.
What about Didi and Andre? Any thoughts on that one?
Didi, you want to take that?
No, go ahead.
I think I think communities are so variable, and local politics, capital and lower peer so variable that I don't think there's one template that fits any one mold. One thing I will point out though is when CBOs are treated as an in-network partner, to some of the points that the other panelists have made about the contracting, like there are processes, utilization management approaches, credentialing approaches that then can be replicated and applied, if appropriately customized, to create efficiencies. The other consideration is also it's really important to think about economic development and the halo, like a virtuous halo effect of investing in CBOs in a way where they're taken seriously as small businesses, which are commonly run by non-white, non-male, non-heteronormative owners. And that creates a really interesting productive cycle of elevating socioeconomic status. And not that we're in the business of economic development per se, but like that's going to happen. Either it's going to happen poorly or it's going to happen not poorly. And so I think that's a lens that has to be applied as well in thinking through some of these partnerships and I guess templates. Shruti, if that's what it looks.
Any last thoughts, Didi, before we conclude with 1 minute left?
No. I just want to say again, Soul Train.
I love it. I really do appreciate that. I pride myself on ending on time because I know you all are super busy. We really appreciate you all joining us for this conversation. To our panelists, to Dr. Bob Ross, who did our opening remarks, truly such a wealth of information. This discussion has been amazing. To our attendees, thank you for joining us. We will be sending out, as I mentioned, the recording for this session, as well as the answers to all your questions. And so if you haven't, please register for this event so we have your email addresses and can send that out to you. Next webinar will be in November. The one after will be in December, again, focusing on data and funding. So we hope you will join us. Have a great day. That's it, guys.